The purpose of our meeting today is to talk about heart disease, specifically when it comes to the female gender. Heart disease is the #1 killer for females in the United States of America. I think this point has been hammered, but has been hammered mostly for men. In 2013, about 1 out of 4 deaths is related to heart disease in one way or another. About the same number of women and men die each year from heart disease. So as much as we would like to make this special and say, well, there's a difference between men and there's a difference between men and women, the truth is this affects all of us. So why is this important? Like I said, #1 killer, and it's the leading cause of death in almost any ethnicity, whether it's African American, white, in the United States, or around the world actually, as a matter of fact, and also among Hispanic women, American Indian, Alaskan Native. You get the point, right? Almost everyone indiscriminately is affected by this all the time. Almost 2/3, 64% of women who die suddenly of heart disease had no previous symptoms. So we're saying 2/3 of ladies who actually die of heart disease never really had any symptoms to worry about before. So as far as they know, they are well and healthy. There's no problem. Why are we having a special talk about women? Why are they different from men? The difference between men and women, that women have different hormones. Their symptoms can also be less recognizable. They're not exactly the same. They don't present with the usual symptoms that men present with. And they're misdiagnosed. When they're first discovered, when they first present with a certain symptoms, they're misdiagnosed. It's called something else. It's called acid reflux. It's called panic attack. It's called many things, but not the heart. Women age 45 and younger are more likely than men to die within a year of their first heart attack. Most of the time, 2/3 of them don't even know or have never had any symptoms. Then when they do have a heart attack, what happens in that first year after, we have found that their outcomes are a lot worse. 65% of them, they said that they wouldn't have even called 911. 2 to 3 times, men are more likely than women to receive definitive life-saving therapy. Because we presume, or the trends have been in healthcare, that when a man presented with a heart attack, that they are sicker. And therefore, we have to give them more definitive life-saving therapy, such as a defibrillator. And previous studies and clinical trials have been done with inadequate number of ladies. So if I told you that it is the leading cause of death in men as much as it is in women, how come in our clinical trials we had far less females than we had males? So we have less information as well. Finally, 3/4 of the clinical cardiovascular trial do not report gender-specific results. It doesn't tell us really what's the difference, what happened with the females as opposed to what happened with the males, because they were not designed that way when they were designed. We just grabbed all the patients, went ahead and did the trials as best as can be done. I've been here now for about 9 years, and you will see throughout my talk, there are some specifics and special things about Genesee County that would be interesting to know. So remember how I told you Genesee County is a little different? The redder the line, the more disease there is. That's all I can tell you. So look at the concentration around you and try to see where we are. Okay? We have a lot of heart disease here. This is something to be upset about, but by the same token, it's something for us to be aware of and do everything we can to make it better, right? Let's look at Michigan itself. Remember what I said, the redder, the worse. Where are we? We are pretty red. Lack of access to care, poverty can also contribute to that for sure. The fact of the matter is, at any age except when you are over 80, men have more heart disease than women, okay? But there's a catch-up. The longer women live, the more disease they develop, and they pretty much become equal to men after 60, and they pass them after 80. that women are just as much at risk of heart disease as men are. And therefore, the recognition and the early treatment is very, very important. About 46 females who had heart attack are going to be disabled from that heart attack compared to their male counterparts. Now, I can't give you an exact answer for why that is, but if you want to think about it, it's probably lack of proper follow-up, lack of aggressive care, lack of risk factor modification, lack of definitive treatment to get the problem out of the way. But we're not here to talk about bad outcomes. We're not here today to talk about how much people die from heart disease. We're here to create more hope and to give you and empower you with information that can get us away from that red zone and get us somewhere much, much safer than that. I want to talk to you about this triad, the prevention that comes from education that leads to an intervention that can help you after today. The good news is that the trends of dying from a heart attack over the years, whether you are a man or a woman, has decreased tremendously over the years. That means we're doing so much better. We have so many tools that can save lives in the immediate occurrence of heart disease and after that. We also have tools that prevent the recurrence of problems. So we're going to talk about before having a heart problem, if you're having a heart problem, and what happens after that. This is how the heart looks, right? The heart, it functions like a pump. And that pump is the essence of life because that's what pushes the blood to the rest of the body, takes it back, and clears it with oxygen, and then pushes it back. These little red pipes here are the coronary arteries. These are the arteries that supply the heart with the fuel that it needs. When it is blocked, this is when a patient develops a heart attack. When a patient develops a heart attack, part of that heart muscle becomes weakened. And when it becomes weakened, we get into heart failure. We get into a weak heart muscle. Or if we have problems like high blood pressure for many years and the heart muscle becomes stiff, does not relax, and therefore we get into another type of congestive heart failure. If you take a schematic of this heart, look at a normal artery and how the inside of it looks nice and clean. We wish we all looked that way. And a blocked artery where we had a buildup of cholesterol within the lining of the artery, causing this essence of life that passes through the artery to be significantly obstructed. How do we get from that clean pipe to a pipe that is blocked and has significant amount of cholesterol and blockade in it? Well, for years now, we have blamed this significantly on what we call an atherogenic diet, a diet that leads to atheroma, the buildup of cholesterol and plaque inside our arteries. We have so much food around us that we know is not very good for us, and we have a lot of it. Add to that bad weather, then you have a sedentary lifestyle. Who here doesn't have a car? Who goes to work biking or walking or takes on an active lifestyle unless they really think about it and make it a goal in their life? When the artery is blocked, as I explained to you before, a portion of that pump dies. I'm trying to get this closer to your mind so you actually know it exactly. So if you have this muscle that keeps pumping the blood, and let's say part of it is not working, so the car that's running on 4 cylinders is now only running on 2. It can't get up to 80 miles per hour. It can do 20, 30 miles per hour. When it gets to 40, it becomes really hard for it to keep going, right? So what can you do before you get a heart attack? Doc, how can I get this problem out of the way? What can I do to improve my risk factors and reduce the possibility of getting a problem in the future? Well, there are the numbers that you all should know if you're not aware of it. Know your blood pressure. If a patient has an uncontrolled blood pressure and they come to the office and the blood pressure has been 160, 170 for years, what do you expect is going to happen? Ultimately, something is going to give. When we are younger and things are going well, it's not as much of a problem. Similarly, that issue has to be treated by a professional. Certain medications work for certain patients. Certain medication can cause trouble for certain patients. So it's truly not something that can be left to be treated without significant care. One of the problems with high blood pressure that it doesn't give you any symptoms. If somebody has, stage 1 hypertension or stage 2 hypertension even, and they're walking around not feeling anything, they're simply not going to feel anything until it becomes a problem. This is why this is an issue that has to be taken care of early. Secondly, ask yourself, when was the last time you spoke to your primary care doctor, or you even seen a primary care doctor, and you asked them, am I diabetic? What are the right numbers that should be checked for to make sure that I am not getting into that diabetes phase, and is that diabetes being treated? I can't stress this one more. I'm going to say hopefully everyone in this room does not smoke. But if you do, it's a very serious problem. There's no ifs and buts about it. I love the story when someone tells me, my 93-year-old grandfather lived until his God knows what, and he's smoked all his life. You're probably right, because there are always extremes of anything. Maybe there are 2% of people that have never smoked and had heart trouble, and then 2% of people that smoked all their life and had heart trouble, but everybody else in between probably smoked and had heart trouble. Where you want to focus is not to be part of those. Now, the good news that today there are ways to help you quit smoking. The one thing that nobody can do but you is to convince yourself that it's worth it and that you must do it. As much as there are bad choices when it comes to our food, there are some healthy choices. And we are able to make those choices if we consciously think about it. Now, the change, the impact of that is not going to be in a day or two or a month or two. But if you are 70, you can do better at 80 if you've done a better diet all that time. And it can be at any age. There's really no limit on when you can make a good thing even better. Thirdly, limit your alcohol intake. And we'll talk about that. The impact of alcohol on the heart is truly significant. And when I asked a patient in my office today who happens to drink a lot, what do you think the impact of alcohol on your body? And can anybody tell me what you guys think he said? Liver, absolutely. But it's not just that. Excessive alcohol use can cause very weak heart muscle that is very difficult to reverse. It might not cause a heart attack. It's not one of those things that is known to cause a heart attack, but it certainly can cause cardiomyopathy, which is weak heart muscle, and congestive heart failure that becomes very difficult to treat. And finally, lower your stress level. I'm going to show you, this is a little bit of a long presentation, so bear with me. I'm going to show you how stress levels can actually harm you more than you think, and in ways that you probably didn't think about. Primary prevention. These things that we spoke about, what could we improve if we've controlled one of them? Just one of them. If we just control the cholesterol, no matter what age you are, you have from 60% to 40% to 20% reduction in primary problems, in primary heart attacks, just if you controlled one of those variables. So we talked about prevention. What do we do before? Let's talk if somebody is having a heart problem. This is their first point of recognizing that there's a heart problem going on. The problem with ladies that the symptoms are completely different, can be completely different. Men have chest pain, it's going to their left arm. We know we should go call 911, go to the emergency room, right? That in women, it could be just abdominal discomfort, my neck, my jaw's hurting, my shoulder. And as much as we see people coming to the emergency room with those symptoms, and we tell them, oh, there's nothing wrong, go home, that's okay. Because if something was going on, that would be the right time to treat it. And the tools that we have are not something you can have at home to know what's right and what should be done. So the symptoms could be no symptoms, could experience serious, symptoms like men, chest heaviness, pain going to the left upper extremity, sweating, pain in the jaw. It could be during rest. it could be during physical activity, and unfortunately it could be during mental stress. Why? Because that puts as much stress and increases the heart rate and increases the production of all these hormones that can lead to spasm in the arteries. But the problem is, ladies are a lot less susceptible to describe their symptoms in a usual manner. It's just the way God made you. You describe things in a less specific way, or at least that's what the clinical trials have shown. Other signs could be breaking out in cold sweat. It could be simply shortness of breath, and unfortunately, it could be silent. So what can we do? If a patient comes with these unusual symptoms, and they come to the emergency room, they come to Hurley Medical Center, they come to the emergency department complaining of those unusual symptoms, the first thing you're going to get is an electrocardiogram. An electrocardiogram can tell a lot about what's going on in the heart. It could reassure you and tell you that there's nothing going on and everything is safe, or it could tell you that someone is having an acute heart attack. And when they are, we have ways to immediately intervene, go through the femoral artery in the leg or through the radial artery in the arm, all the way up to the heart, with the purpose of finding that blockage, opening it up with a balloon, and leaving behind an open channel. That open channel will take the blood to that area of the heart before it completely dies. The final goal is not just to relieve the pain, but to not leave a scar, so the pump remains strong, and to not leave a scar that could cause abnormal heart rhythms that could lead to problems down the road in life. What we do after we do the balloon is we leave a mesh behind, a metal tube that we call a stent, that allows the blood to go through. The benefit is not just when you arrive or when you get the treatment, but rather it is life-lasting forever. Is the treatment for heart disease in men different in women? Well, in the acute phase, if it's a problem of blockages in the arteries to the heart, which is my specific, extra specialty, then the answer is no. We need to get blood to the heart, whether it's a man or a woman. The difference is, and this is going to surprise you. See, when I was in medical school, when I was even beyond that, when I was in residency, I was told a premenopausal woman would never get a heart attack. My, how wrong is that? It is so wrong. It is so not right. And I have seen it so many times that unfortunately, I believe many ladies have gone through life not recognizing that there was a problem. Secondly, healthy lifestyle and change in medications, that really doesn't differ between men and women. And finally, what we call cardiac rehabilitation, what to do after an acute event. This is something both men and women need. So what do we do after heart problem? Well, whatever that cholesterol was, it has to go down significantly. And this is an important one. The guidelines for cholesterol have changed over the years. They continue to change because we have different trials, and those trials show us different results. One of the most difficult things for me to explain to a patient when they come to the office, they say, "But doc, my cholesterol is normal." I have a question for you. What's normal? If somebody's cholesterol or bad cholesterol, which we call the LDL, is 100 and they had a heart attack, is that normal? It's not normal. There was too much cholesterol. It built up in the arteries and it caused a blockage. So that needs to be lowered. It's not normal. And if another guy's cholesterol is 100 and they did not have a heart attack, they don't have risk factors, I'm not going to call it normal. I'm just going to say they don't require treatment. So we don't know what normal is. We know that this cholesterol, based on the clinical trials that we have and the risk factors in each and every patient, requires to be lowered or does not require to be lowered. And that's an important thing. When you hear someone say my cholesterol is normal, please correct them. Tell them maybe your cholesterol does not require treatment. Now, could this change in 5 years or 10 years with new data and new information, new clinical trials? Of course. Everything that we're saying today is based on what we know today. And that's how clinical science is. You can't really rely on just conviction. You have to have clinical evidence that what you're doing is correct. Being physically active on a daily basis is another big important point for me. Not a lot, but some of the patients who end up with heart disease and heart problems will come to the office and say, Doc, can I get a handicap sticker? Anybody guess what my answer is? No. Absolutely not. I want you to park as far away as you can and walk all the way here, with one exception, extreme cold weather, because extreme cold weather can really be harmful. So the point is, we treat people with heart disease, and this is one of the reasons people ask me, why did you become a cardiologist? I'll tell you why. We treat people with heart disease so they can become better, more active, more involved in their life, live longer and feel better, not the opposite. Not so they can get a handicap sticker, park away, not do anything, and sit home. That's really not the goal. Weight control. Let me suck up my belly. Weight control is very important. Now, I'm not saying weight reduction. I'm saying weight control. God did not make us all equal in the way we look and the shapes that we are. We're all different. So the point is, try to control the weight. Try to do better than what you were doing. Whatever it is that you're going to do is an improvement from before. The guidelines for cholesterol continue to change. They don't change, hopefully, because of drug companies or what drugs we have available. They hopefully change because of clinical trials that have evidence towards what do we do. But there's one thing that we know for sure and proven in multiple clinical trials. Lower is better. Now, how do we get lower? Whether we get that by physical activity and modifying our diet, which is the number one method that we all should use, or whether we get to this by taking statin medications or taking, other medications that can lower the cholesterol. And by the way, more recently, there's been actually even newer medications that are injectable that lower cholesterol that I expect in the future will also play a role based on what we see by the clinical trials. You need to know all the tools that you have in your armamentarium. You can't just rely on one or two. I see a lot of patients who've had heart attacks who are being treated by weak statins. The guidelines say against that. We should be aggressive because the benefit long-term by being aggressive is very significant. People live longer by controlling this problem. All right, so what are the risk factors that we've been talking about? Unfortunately, diabetes is not just a disease, it's an epidemic. And the numbers keep getting lower, so people who were not diabetic 10 years ago are now considered diabetic simply because we think, or the medical community based on evidence thinks that the numbers should be lower. So diabetes is a big risk factor. And once someone is diagnosed with diabetes, then they should take extra care to take care of their heart, their blood pressure, and their cholesterol. High blood pressure, we kept harping on that and talked about it a lot, and I can tell you that the guidelines for blood pressure have also changed over the past few years. But the changes are still within reason. Family history is a very big one. If I have a patient, even if the patient was very young, whose parents died from heart attacks at a young age, that definitely should be an alarm bulb to know that there's a problem in this family history. Anybody thinks, what is the youngest patient that you think I've ever treated with an acute heart attack? Give me a range. Anybody thinks 40s?
25, 16, 30, 35.
26 is the youngest. 26 is the youngest. I've had 3 who were 28. And we're talking they had acute heart attack. We're not saying, they came and it was something mild. We're talking about something significant. We talked about this again. I have to mention it about 1 million times because there are what we call modifiable risk factors and non-modifiable risk factors, okay? So the non-modifiable risk factor, we used to think, and we think it's still true by saying we as medical community, is age. I can't change that. The older we get, the more things will break down. So that's a non-modifiable risk factor. There's nothing I can do about it, right? But the one modified risk factor that if we change has the biggest benefit, the biggest reduction in risk of events, is smoking. So if I take all the medications that I give a patient, put them in one side, and put quitting smoking on the other side, I'd rather they quit smoking and not take any medication. We used to talk about this thing called metabolic syndrome. Anybody heard about this? If you heard about it, raise your hand. Yes, thank you, sir. It's a very rare term that talks about a constellation of things: excess weight, decreased good cholesterol, increased blood pressure, increased blood sugar, and high triglycerides. It's basically a disease of the 21st century. It's a disease of sedentary lifestyle, eating bad, and not doing anything. Patients who fit that description, excess weight, high blood pressure, high sugar, definitely are at risk. But again, the purpose is not to scare them. The purpose is to tell them we need to recognize that and we can improve this. So what's the bottom line? Ask yourself, if you haven't been checked for diabetes, please do so. Speak to your doctor, whether you're a man or a woman. But remember that if you are a woman, the stakes are probably higher because you're getting less attention to that problem. What are my other risk factors? What happened in my family history? Am I smoking? Is everything really being addressed? And have I been checked or evaluated for those risk factors? And this is, I say this to all my patients. So if I'm going to leave you with anything today, please remember this. Raise your hand if you promise to remember this. Okay, so I have everybody awake. Someone there didn't raise their hand. Raise your hand, sir. You got to promise. Who cares about you the most? Nobody cares about you more than you. Nobody. Not your doctor, maybe not even your family. So when you walk to your doctor's office and you say, I take the red pill and the blue pill and the one that's really small and tiny, you need to know what you're taking. If you want your doctor to take care of you, you need to take care of yourself. You need to know what you're taking. Therefore, there is no shame in being an active participant in your care. How can you be an active participant? Well, your doctor may be a great doctor, but he forgot to check something. Maybe he didn't know that you have a strong family history. Maybe he did not know that your blood pressure has been running high. Be a participant. Give them that information. And if they are doing their job right, they're going to listen to you and they're going to try to address that problem. So what are those numbers that we're looking for? We're looking for a good cholesterol to be high. We're looking for the triglycerides to be low, the blood pressure to be generally under 140/90, the fasting glucose to be under 100, the body mass index, which is a complex calculation. In short, it means way less, and the waist circumference to be less than 35 for men specifically, and minimum of 30 minutes of activity in 5 days out of the week. Now, what does that mean? I don't expect everybody to run a marathon or do CrossFit or do anything insane, but just be active. You will be surprised if you ask yourself, have I done 30 minutes in the past week for 5 days? That could be just a brisk walk for 30 minutes. And I actually have to blame this more on my older patients than I do on my younger patients, because a lot of them may be retired, have the time. What are we going to use the time in? The time can be used in employing a lot more physical activity. So what's so special in these specific risk factors about women, since I'm blessed to have you all here today? Well, women with diabetes are actually at greater risk of heart disease than men. Don't ask why, it's just the way it is. That's what research has shown. Mental stress and depression is something that women don't have more of, but rather are more affected by when it comes to their heart than men. There's proof to that. I'm going to wake you up again in a second. Depression makes it difficult to maintain a healthy lifestyle. If you're depressed, if you're unwell, you're not going to go out and exercise and have a healthy lifestyle, right? You're not going to make healthy choices. You're just going to eat what you find in your way. Inactivity becomes a major risk factor for women, as research have shown, and also inflammatory diseases. You all have heard of lupus, rheumatoid arthritis, other diseases that actually affect women slightly more than men. And when those blood vessels are inflamed, the impact, particularly in women, is higher than it is in men. Finally, menopause. Remember how I told you in school they told me premenopausal women don't get heart disease and how that's wrong? Well, that is wrong. However, once a woman goes through menopause, then there are lower levels of estrogen. And those lower levels of estrogen are significant risk factors to develop smaller arteries. And those smaller arteries get in trouble a lot more. So what happens in menopause to the cardiovascular system? Well, the frequency of coronary disease before menopause is lower, but it's definitely not eliminated. It's still there. So without trying to get into a smart clinical trial, you could tell that a heart usually healthier premenopause than it is after. And I think the difference, what we have found from clinical trials, is what's called endogenous estrogen. See, when ladies in the past used to take pills post-menopause to improve their symptoms, they ended up having more heart problems, which is weird because if you think they had estrogen before menopause and things were well. So how come when they're ingesting it as a pill, it caused them to be in trouble? Well, the difference is the following. This is endogenous estrogen. This is made by the human body, as opposed to something that we get in a pill and take later. And endogenous estrogen was found to reduce the bad cholesterol, raises the good cholesterol, and has a favorable effect on the function of the blood vessels and on inflammation. Remember how we said earlier how depression affects women more? So about 15 years ago, we started to recognize people coming with acute heart attacks, full-fledged heart attacks, every symptom of a heart attack, EKG changes, increased blood enzymes, chest pain. They're in shock. We take them to the cardiac cath lab, and guess what we find? Nothing. We do find dead muscle. We do find that part of the heart is not squeezing well, but there's no clot in the arteries. There is no blockage for us to open. And as time went on, this was found mostly in Japan, actually. And in Japan, they used, when they get the octopus, they put it in a little jar. And that jar looks like that. They call it takotsubu. And we found that the heart that has that problem has the same configuration. It looks like ballooning up in the heart instead of nicely squeezing. And it looks like the jar. A few years ago, what we have found, 90% of the time, if not more, the patients who present with this are women, not men. A lot of times it's preceded by severe mental and psychological stress. So the Americans called it broken heart syndrome. We have since changed the nomenclature, and now it's called stress cardiomyopathy. So remember us talking about stress earlier? So it is no joke. Stress could certainly cause a heart attack even if the other risk factors are not present. What about pregnancy? Doesn't happen in men. That's the first thing. But I'm here to tell you that I have unfortunately done a heart catheterization, and a patient who was pregnant had a tear in one of the arteries in the heart, and I had to put a stent. And she was in her 20s. Pregnancy sometimes causes problems, particularly if the patient has diabetes and high blood pressure. And they certainly immediately after delivery have significant increase in hormones that can sometimes, but rarely, very, very rarely, cause a problem in the heart. Also, what happens rarely is patients, females, post-pregnancy who develop a weak heart muscle. And for those, when it happens, we tell them, don't get pregnant again. Because if you do, the risk of death is extremely high. What else can we do? Exercise more to reduce the risk. Now remember, when we say the word exercise, this is a relative thing. If you have never exercised, don't expect to run at 6 miles an hour on the treadmill. Walk. Any activity, any change is going to be positive because it will produce those hormones that are going to help in general. Moderate exercise can be walking on most days of the week. Even authorities that look at this, the Department of Health and Human Services recommends 30 minutes, 5 days a week. If you want to get healthier and you're able, then increase it to 60 minutes. And if you want to do strength exercises, that's also helpful because ultimately that's going to allow you to walk more and be able to tolerate more. Try breaking up into that physical activity. So if somebody tells me, Doc, I have a lot of arthritis, I can't do this, I can't do that. Well, it doesn't have to be contiguous 30 minutes, especially if you have the time. Break it up, 10 minutes in the morning, maybe 10 minutes at night. That will make a huge difference. Also, make changes to those activities all throughout the year. If you started somewhere, try to think, okay, how can I get to a completely different level? Now, I'll be honest. Amongst my patients, I'll say it's about 50-50. 50% will make a definite healthy changes in their life, and 50% will not. But here's the good news. Here's the good news. See, the common theme when somebody presents with heart disease, when it's too late, and I'm hoping it's not too late for anyone, is sadness, despair. Something bad happened. Well, I'm here to tell you that I've been here for about 9 years at Hurley, and we've treated patients 9 years ago who have not had a problem for the past 9 years because they made so many changes to their life and they've become so much better. And as a matter of fact, they actually feel better. All right. Thank you for listening. We appreciate it. This is the end of this discussion. I'm happy to answer any of your questions. I hope that you, going out of here, went with a message of hope, how to improve your heart health, how to look for ways before heart disease happens if you're concerned, how to modify your risk factors, how to deal with disease if it did happen, and how to make changes in your life after that. Please know that a lot of the things that we spoke about and this talk that's being sponsored today is being sponsored by Hurley Medical Center. And at Hurley, we've made a lot of strides to bring real options for patients, amongst which is our cath lab, who's treated more patients with acute heart attacks than I can count or remember, and I've been blessed to be part of that for many years. The cath lab brings excellent technology. There's nothing that is safe to be done that we cannot do. Furthermore, Hurley has actually made a lot of strides in the past few years to bring the cardiac rehabilitation center into the hospital and make it state-of-the-art place where patients do get better, and patients do get better. So with this, I'll conclude. Thank you very much for coming, and I'm open to any questions if you have any.